Hello everyone, and welcome to Quick Med, where medicine is explained quickly and easily. Today we'll be discussing the stages of syphilis, so let's get to it. Alright, so let's just start with an overview of syphilis. It is caused by Treponema pallidum, which is a spirochete. It is a sexually transmitted infection, and so it does require exposure to an open lesion where you have organisms present. This can be due to a chancre or due to other lesions that we will discuss. But another mode of transmission to remember is transplacental passage, which is when mom is infected with syphilis and transmits the infection to the fetus. Syphilis has been called the great imitator as it can present with a wide range of symptoms and it can also affect a number of different organs. So let's now get into your stages of syphilis. We have our primary, secondary, and tertiary syphilis, and then there's also another stage called latent syphilis, which is broken down further into early latent and late latent. That was a little bit of a mouthful, and we will discuss that a little bit later, but let's get into primary syphilis first. Primary syphilis is probably the stage that we most likely think of when we think of syphilis, and this is where you get the chancre. And this is a lesion that presents first as a papule. It starts as a raised lesion, and then progresses to this painless ulcer that has a raised, firm border. And painless here is the key term to look out for because there are some other lesions that are usually more painful, so that can help you distinguish between the different causes. And patients can also present with bilateral lymphadenopathy, and this is usually going to be regional, so within the inguinal region. And this is because primary syphilis is still more of a localized infection. The chancre typically presents within about 21 days, that's the median incubation period, and it typically heals within 3 to 6 weeks. What's interesting is that it can heal even without treatment, so spontaneously. And this is interesting because patients might not even know that they had these lesions and have it go away before they're even able to detect it, so they can have syphilis without really realizing it. Now, when we get into secondary syphilis, this is when your initial local infection becomes widespread dissemination, and this usually occurs over, weeks to months. Patients can have some vague constitutional symptoms like a fever, sore throat, malaise, which is extreme fatigue, myalgias or muscle pain, and weight loss. They can also have lymphadenopathy, which we also saw with primary syphilis, but this time it can be much more diffuse, so in the cervical region and elsewhere. Patients can also present with a diffuse rash, and this is actually the most characteristic finding of secondary syphilis. The rash is symmetric, so it should present on both sides of the body. It usually affects the trunk, the extremities, and especially the palms and soles, and this is something to look out for because there are only very few rashes that usually present on the palms and soles. Patients can also present with a mucus patch, which is where you have these erosions that present on the tongue and the oral mucosa. They can also present with condylomata lata, which are wart-like lesions that are usually present in the genito-inguinal area, and just don't mistake this for condylomata acuminatum, which is where you have warts that are caused by HPV. And now that we're in a more disseminated stage of the infection, you can also have internal organ involvement. So you can have hepatitis. You can also have kidney involvement, which can present with mild albuminuria to a nephrotic or nephritic type of syndrome. The bones and joints can also be involved, so you can have a synovitis, osteitis, periostitis. I wouldn't worry too much about having to memorize all of these different presentations, but just knowing that there are different organs that can be involved in secondary syphilis is important to know. And now we get into tertiary syphilis, where you have to have either one of these findings, so gummatous involvement or cardiovascular involvement. Let's start with the gummas, which are lesions that can occur anywhere in the body, and they are raised lesions that actually are granulomatous in nature. And then you can also have cardiovascular involvement, which typically affects the aorta, specifically the ascending aorta. And you can think of this as a vasculitis type of picture where you have weakening of the aortic wall, leading to dilation of the aorta as well as aortic valve regurgitation. And just keep in mind that tertiary syphilis is a form of late syphilis, so this typically can present, years after the primary infection in a person who contracted syphilis but was not treated for whatever reason. Let's now talk about neurologic or ocular findings, and what's important to know about this is that it can occur at any stage of infection, but typically you see this more with secondary or tertiary syphilis. Neurosyphilis, interestingly, sort of has two different forms depending on how early or late you are in the infection. Early on, you can have more involvement of the CSF, the meninges, and the vasculature, so this can lead to things like headache with the CSF involvement or meningitis, or even strokes. And then later forms typically affect more of the brain and the spinal cord, so you have more of this general paresis or tabes dorsalis, which, if you remember from your neuroanatomy, is where you have involvement of the dorsal columns of the spinal cord. And that portion of the spinal cord actually helps with proprioception, which is our awareness of our position and movement of the body. And so when this is affected, people can actually have difficulty with walking, so they can have gait imbalances. And along with neurosyphilis, there can also be ocular findings, and this typically presents as uveitis, which, to speak very simplistically, is a type of eye inflammation. All right, so let's talk about latent syphilis a bit, which is when patients are completely asymptomatic but will present with positive serology. So this will usually be detected on some sort of, screen that is done for patients. We have our early latent syphilis, which we talked about, and this is when you are sure that the person had contracted syphilis within the last 12 months. And this can be through a wide variety of situations, so let's run through them. If a patient presents with positive serology and they tell you that their first sexual contact happened within the last 12 months, then you can be pretty sure that they're still in the early latent phase. Another situation is if they've had sexual contact with a partner who was diagnosed with syphilis during this time frame as well. Another situation is if the patient can recall symptoms that are consistent with primary or secondary syphilis during the last 12 months. And a final situation is if a person had syphilis and was treated and can demonstrate increased titers on labs during the last 12 months. And then if a patient does not meet the criteria for early latent, then they're automatically placed in late latent. And this is usually when a person has positive serology, but you're not entirely sure when exactly they contracted syphilis. And the reason why we distinguish between these two stages in the first place is because it actually affects the treatment regimen. So people who are in the late latent syphilis need longer treatment. Let's go over this practice question to see how a question on syphilis can present. Here we have a previously healthy 25-year-old female who comes to the clinic because of a painless lesion on her vulva for the past 4 days. Remember, painless being a key term. She is sexually active with one male partner and they do not use any contraception during intercourse. And here the mention of not using any contraception should raise your index of suspicion that this might be more of a sexually transmitted infection that we're dealing with. A physical exam shows a 1.1 centimeter non-tender, sharply demarcated, elevated round lesion on the vulva. So here again, we're seeing that it's non-tender, so this is more of a painless lesion. And if you remember our discussion on chancres, we said that it can start off as a papule and then become an ulcer. So this sounds like it's more of a chancre that's in a papular form. And then the base of the lesion is smooth, the lesion is non-purulent. What is the likely diagnosis in this patient? So this sounds a lot like a chancre, which is the primary stage of infection in syphilis. All right, and there you have it. I hope you found this video helpful. If so, please make sure to like and subscribe because that just helps our channel a little bit more. And as always, good luck studying, everyone.